Ma'am, please start in 3, 2, 1.
Namaskar and good evening, everyone. I welcome you all for today's webinar on Onco Forum 2025 Multidisciplinary Cancer Updates. And with immense pleasure, I would like to invite the convener for this program, Dr. Asim Samar, who is Senior Consultant Medical Oncology at BMCHRC Jaipur, for the welcome and introductory note and to take the proceeding further. Over to you, sir.
Thank you. Thank you, Team Horizon. In this 2025, we are ending with the year, and there are a lot of things to discuss about the breast cancer, and especially in the medical oncology field, we have progressed regarding immunotherapies and the newer molecules. But as we are progressed in one direction, possibly the surgery is also progressed in a very good way. So it's a holistic approach which by which we can give benefit to the patient. So it's always knowledge sharing will impart in our clinical practice, and this practice will change the life of the patient, and we can offer the good treatment. For this motto, we have organized this webinar, and to grace this webinar, uh, we have very esteemed faculties and panelists and speakers. So amongst them, uh, Dr. Uttam Soni is very well known in entire India and especially in the Jaipur. So sir is consultant oncoplastic breast surgeon in Jaipur Breast and Cancer Research Institute at the Sita Devi Hospital, Jaipur. So he will be moderating a session where surgical part will be discussed, and the topic is very you can say the very important topic, de-escalation in surgery for axilla. And we all know de-escalation is sometimes required. Why? Because the after effects of this kind of massive surgery, where you remove all the lymph nodes or maximum lymph node, and then patients breast cancer is treated, but the life is little bit uncomfortable because of the lymphedema and other problems. So sir will throw some light on this particular topic with his volatile moderation we have seen in various meetings. So I would call upon the stage Dr. Uttam Soni sir. So sir will introduce his panelists also, or if I can do that, sir will permit me if we will do that.
Asim, please do that. Please do that. Thank you for
Yeah.
having me here.
So good to see you, sir. So in the panel we have Dr. Sarika Lamba. She is a consultant oncology surgery in the Narayana Multi-Specialty Hospital, Jaipur. Dr. Megha Tandon, she is professor in general surgery, VMMC and Safdarjung Hospital, New Delhi. Dr. Garima Daga, she is the senior consultant in surgical oncology department in Rajiv Gandhi Hospital, Rajiv Gandhi Cancer Institute, Sector 5, Rohini, Delhi. And then Dr. Anand Mohan, he is our dear colleague. He is associate professor surgical oncology in the MG Mahatma Gandhi Hospital, and Dr. Kapil Dev. He is a surgical oncologist in SCG Cancer Center, Jaipur, and Dr. Jeevan Ram Vishnoi. He is an additional professor and head of the department in surgical oncology in the AIMS Jodhpur. So with this list of and constellation of panelists, Dr. Uttam Soni sir. So you please proceed with your panel discussion, and we will be surely enlightened with the recent knowledge of the surgery. Please, sir.
Thank you so very much, Dr. Asim and team Horizon, for having me here for this lovely Onco Forum 2025. And the topic given to me is something which probably all the surgeons would like to, not like too much, because this is getting them out of the business. I hope all of them agree. Now, to start with, can I have the slides, please? Or do I share it from my...
Yes, sir. Anyways, whichever ways you want, sir. We'll
Okay,
share.
let me have it from my way. So the topic is
So can you just make it full screen?
This is full screen now.
No.
You can see
not
that
yet.
full screen?
Not yet, sir.
So this is full screen to me.
So you have to make it full screen and then share.
Okay. Share. So you do it from your side. I'm not able to do that.
Sure. Can you see, sir?
I can.
Okay.
Everybody else can see?
Yes, perfect. It's perfect.
Okay, great. So this is a lovely book to start with. And this was edited by Professor Chintamani, who is one of the stalwarts in breast cancer surgery in India. Sentinel node biopsy in breast cancer. The next slide, please. Next one, please. The biggest lie is I have read and agreed to the terms and conditions. That happens to all of us. Next one, please. All right. So these are two not that old papers from NEJM. The breast, and the one is an editorial from NEJM again. This was in 2024. The first one is axillary dissection. The bell tolls for the de-escalation of loco-regional treatments, time to find a balance. This was from the breast in 2024. And then the letter editorial by Monica Morrow, sentinel lymph node biopsy in early stage breast cancer, is it obsolete? All these papers, they basically insisted upon, or they were guiding that somewhere for selected patients, selected group of patients, we can actually go or do without any sort of axillary staging. Next one, please. Okay, so here we come. My first question to, is Sarika around? Sarika?
Yes, sir, I'm very much here.
Sarika, how are you?
All good, sir. How are you doing?
I'm doing wonderful. Thank you. So, Sarika, just to begin with the discussion, whenever you see a patient and you see a clinically node negative patient, how do you proceed with that?
Sir, the most important thing, if it is a clinically node negative, it doesn't mean that it is not a node negative patient, right? So we have to do some sort of imaging to see the axillary nodes. So normally we prefer doing ultrasound. And at our center, we have a mammography which is adjunct with the ultrasound. It is supported by the ultrasound. So we have, after discussion with our radiologist, we specifically look for the any axillary lymph nodes which look suspicious, like if there is any globular node or a loss of fatty hilum, or if we are finding any other small, even if it is a clinically non-palpable, it's a small node, we look at the ultrasound imaging to confirm that it is really node negative.
Great. So what Sarika wanted to tell is clinically node negative axilla does not always means that we do not have any disease nodes in the axilla. We can always have it. What do you think the percentage of these patients is in your practice, Sarika?
Sir, we in my practice, clinical practice, what we have seen is around 15 to 20% patients, those who are clinically node negative, are found on ultrasound found to have a suspicious node. That is what we have seen.
And we mean suspicious, or we mean a positive node on further
Sir, the
investigation?
15 to 20% suspicious nodes, and when we have we have done a tissue biopsy, or it's like an FNAC. We have found almost around 80 to 90% in those patients are found to be a positive metastatic lymph nodes, actually.
What is the percentage? So okay, thank you, Sarika. Megha, you also come across these patients because you have a busy practice, isn't it? So
Yeah,
these sort of patients you also see.
yes. Yes, sir.
So what is the percentage of patients that you get in this cohort who is clinically node negative but suspicious and then positive on biopsy? How many patients do you see as with micrometastasis and macrometastasis?
Right, sir. So basically, if a ultrasound suspicious, we are blessed with very good breast sonologists who are like dedicated. So 90% of time, if they say axilla is involved, it is we've proven that it is involved. So we actually they do all the which are like suspicious looking lymph node. We do an axillary FNA or biopsy, and 90% of the time they come to be positive, as was previously said. There's a similar figure we have.
All right. And do you guys practice clipping of the nodes as well for these sort of cases?
Yes, sir. But it is done as a part of thesis project, as a part of a study, not routinely, but we do that.
All right. So addressing an N0 axilla, evolution of diagnosis and staging tests. Years back, we used to do ALND for each and every case. Now, from 90s onwards, we were doing sentinel lymph node biopsies. And today, as Dr. Sarika and Dr. Megha has told, very true, an ultrasound for an N0 axilla is being very routinely done. The important thing is this is a person-dependent test. So somebody who is doing it should be fairly experienced so as to give us a correct idea of the status of the axilla. Next one, please. No upfront ALND in N0 patients. Why is the question? And Dr. Jeevan, are you around? Dr. Jeevan, you around?
Yeah, yes.
How are you, Jeevan?
I'm good, sir.
Okay. So, Jeevan, you work in a tertiary care institute. How do you deal with these N0 patients? How do you deal with this N0 patients?
I think we are doing the similar to what Dr. Sarika has told, that we are doing routinely like mammography, that is adjunct by ultrasound, and then if it is like negative, then we will go for sentinel. If it is suspicious, then we are doing ultrasound guided FNAC. If it is positive, and along with that, our radiologist, interventional radiologists, they are doing like clipping of these nodes. So that is also one intramural project. So in our institute. So in that similar way, we are doing it nowadays, because we are also seeing a lot of more and more patients with the node negative axilla. So I think your today's topic of discussion is quite relevant, even in, I think, tier 2 and tier 3 cities also.
You're absolutely right. You're absolutely right. The way breast surgery is going on is less more. So that's how it is. Whatever we are doing, is it more or is it optimal? That's what we need to discuss today, or what we are doing to be able to share our ignorance with everyone. With these patients, why we don't want to do ALND is because they end up having significant post-operative lymphedemas. And then the biology is more important nowadays as compared to what it was in, say, 15, 20 years back. How frequently do you do sentinel lymph node biopsies in your unit? Dr. Jeevan.
Yeah, so we are doing like in almost all cases. Like today also, because we had one case with that So we did Sentinel with we have like support of nuclear medicine department, and we have also like ICG, so that system SPY-5. So we are doing with the dual dye technique. So we are doing in most of all the eligible cases for sentinel lymph node biopsy.
The question is now, how many nodes do you think is optimal for you to be comfortable that you've done an optimal sentinel lymph node biopsy for this patient?
Mostly, so if we are doing with that gamma probe, then I think one node, and that is like background activities coming to near normal. So then I think one node is sufficient. Otherwise, if we are not doing with that, then with the ICG or blue dye, so mostly we will be trying to get at least 3 nodes, so that false negative we will not get in the later period.
Megha, do you do sentinel lymph node biopsies with the gamma probe or the radioisotope very frequently in your unit?
So we are doing sentinel lymph node by dye-alone method. We do use dual method by which is blue dye and ICG sometime. But for upfront, your question initially was how many nodes. So for upfront, even early breast cancer, if it's upfront, I think as said, 1 or 2 lymph nodes are good enough. But if it is after neoadjuvant, we have de-escalated from N1 to N0, and we are getting sentinel lymph node along with that. So at least 3 nodes or more is preferable. So.
Sarika, do you have facility of sentinel lymph node biopsy in your unit?
Sir, we do not have a gamma probe here. So what we are using is basically a blue dye, and along with it, so now we have started the ICG. We ask the person to come and bring the machine, and we do that. We do not have a gamma probe till now, sir.
So not doing it routinely.
Not doing it with. We are doing it with the blue dye and with that ICG. That's
okay. Okay. Next one, please. Next slide. This is a wonderful paper again from NEJM NSCBP B04, and it gives us a very, very nice idea of how the node negative patients were treated and what was the overall result of that. And they were all very comparable. So they had 1079 patients who were clinically node negative, of which we had 37% as T1, 51% for T2, and 11% T3 group. And these patients were divided into 3 groups. One group had radical mastectomy, the other one had total mastectomy, and the third one had total mastectomy plus radiotherapy. The numbers were comparable, 362, 365, and 352. Overall survival at 5 years was almost same. At 10 years was almost comparable. But then at 25 years, there was a difference. Patients with radical and total mastectomy without any auxiliary management, they did well. So this was sort of an eye-opener. This was 25-year follow-up of a randomized trial comparing these 3 modalities. Bernard Fisher did it. Next one, please. Next slide, please. So this is the same that we have spoken. Next one, please. And it says that 40% of node negative disease in the RM arm were found to have positive node. This is a significant number. This is what Sarika and Dr. Megha and Dr. Jeevan has said, that even if it is node negative clinically, we can always have. So this 40% is a big number. 40% is big. And assuming that 40% of node negative patients, they would also harbor in the total mastectomy arm. Important thing is they were node positive, but still only 90% of these develop clinical nodal disease. Median time from total mastectomy to identification of nodes was 15 months, most cases within 2 years. And then these patients underwent axillary lymph node dissection at the time of dissection. So obviously after 15 months or 2 years. Next one, please. So what inferences we have from NSEBP B04? Clinically, axillary nodal negativity is not a reliable method of determining nodal involvement. Microscopic axillary nodal metastases do not necessarily translate and progress into clinically overt disease. ALND performed upfront is essentially largely prophylactic because only 90% of these patients needed surgery later on. And deferring ALND till such time that the nodes become palpable does not compromise survival, as in overall survival, as we saw after 25 years, they were very comparable. TM plus RT had the lowest LRR. It may be considered and serve as a viable alternative to ALND. Next one, please. Dr. Anand, do you have the facility of sentinel lymph node biopsy in your unit?
Yes, sir. We have ICG. We are using ICG alone, shifted to ICG alone.
Okay. So, so if you have an N0 patient to start with, you did a sentinel lymph node biopsy.
Yes, sir.
This patient, and you were able to get, say, like 4. Somebody has some disturbance from behind. Can we please stop it? So you have taken out, say, 5 sentinel lymph nodes in this patient, and 1 lymph node showed micrometastasis.
Yeah.
What will you do with this data?
So if there is single node, then we have option of doing a completion ALND versus doing a radiation to the axillary nodes. We have both the options. We have good evidence for radiation also. And in the, I think, Ambrose trial, they showed that it had lower lymphedema rate with similar oncological outcomes. So both options are there at present. So we can preserve the axilla and can consider for adjuvant RT, especially if patient is undergoing breast conservative surgery.
So let me frame this question again for you in a different manner. A postmenopausal female T1N0 lesion to present with HR positive, HER2 negative, and a Ki67 of, say, 18. Now she has an N0 clinically node negative axilla. You did a sentinel lymph node biopsy. You took out 5 nodes. 1 node is having micrometastasis.
Right, sir.
How will you proceed further?
So in this patient, we can give adjuvant radiation to the patient also. And if she's quite old age and very strong ERPR positive with the lower Ki67, I heard it is 8% or 18%. So 18. Okay, so we may consider her for avoiding axillary dissection, doing complete ALND also for her, and just give adjuvant RT to the axilla.
Jeevan, what will you normally do in your unit for these patients?
If that patient is, I think, below 65 years, then mostly we will consider adjuvant radiation also. So otherwise, if it is, so I think as Dr. Anand Mohan told, so similarly, if it is like elderly, in that select subgroup, we may leave the radiation. So that will be like based on concessions in the tumor board. So mostly this is dependent upon our radiation oncologist. So what is their opinion, accordingly we will. So, but mostly we do in that way.
Megha?
Sir, hello.
Megha?
Can you, sir, I think with micrometastasis, upfront surgery with micrometastasis, I will not touch the axilla, neither by RT nor by surgery. Essentially, it's a N0 axilla. Micromets, if I am very sure of my pathologist, and if they say 1 micromet, I don't need to do anything for that. And I don't think Ki67 determines radiotherapy choice. It can influence chemotherapy and other things, but it should not be. There's no evidence of using it for radiotherapy. If it's micromet, it's essentially N0. I'll leave her.
So what is the evidence for leaving a micromet, not touching it or doing nothing? Do you have evidence for the same?
The Cinomec trial, sir. We have.
Yes. So Cinomec is doing this. Sarika, what do you do for these patients?
Sir, micrometastatic disease in an axilla, we do not do the completion axillary dissection, and she's a young patient. We'll definitely subject her for a radiation therapy.
Postmenopausal, say 65.
So we normally consider it around 6. If the patient's physical status, performance status is good,
You will irradiate the axilla?
Sir, till 65 we are radiating the axilla. Afterwards we are leaving the axilla. Even if it's a micrometastatic disease, we do not do the axillary dissection, and if T1 N micro, we do not do the complete dissection, and we do not give a radiation also after the 65. 65 is our, as discussed with the radiation oncologist, we say till 65 we can give radiation. Afterwards we are not giving that patient radiation.
No, we can give radiation to whoever we want. The question is,
we understand, sir, but till 65 we are giving a radiation, sir.
No,
not giving much.
Does this patient needs radiation or any form of auxiliary management? This is the question. Do you think this patient needs any sort of auxiliary management? 5 nodes taken out on sentinel lymph node biopsy, 1 positive with a very favorable biology, and the metastasis is, it's a micromet.
Micromet.
We do not.
I think, sir. Sorry to interrupt. I think we are talking. Okay, so we are, because that patient has undergone breast conservation surgery. So post BCS up to the age of 65, patient will require radiation to the breast. But for axilla, it's already, because there is no need to give radiation to the axilla. So that is surgery sufficient.
Why is age after post BCS? Like post BCS, most of the patient would require RT.
But I did not mention BCS anywhere.
Yes, sir.
Okay, so we assume that BCS, that's why if it is mastectomy, then there is no need of RT.
Yes. Let's move forward. We have a very young doctor with us right now. Garima, you around?
Around, sir.
How are you?
I'm fine, sir.
All right. So the next question is to you, Garima.
Yes, sir.
So you have a clinically node positive patient.
Yes, sir.
And post NSCT it is N0.
Yes, sir.
How will you proceed with this patient?
So at present, like the nodes, if the patient is node positive to start with, we do a complete axillary dissection. Only if the patient is clinically node negative and post NACT remains node negative, then only we offer sentinel lymph node biopsy. Otherwise, we are not clipping the nodes at RGCI at present because it becomes very messy. So not yet started clipping of the nodes, and if it is node positive to start with, we do a full axillary dissection.
What do you think is the role of sentinel lymph node biopsy after NACT?
So if it is a CN0 before the NACT or NAST and it remains like YCN0 after NACT, then we are very comfortable doing the sentinel lymph node.
All right. So in N1, post NACT, if it becomes N0, you guys are still doing a complete axillary dissection.
But this is because we have not yet started clipping of the nodes. So if the node can be clipped and if the node can be tattooed or can be marked somehow, and that node can again be retrieved post NECT, then like it gives a much more validated result, like if you are doing like with a node positive to start with. But we've not yet started. So at our institute, not yet like we've started with N positive for post NACT.
And how comfortable you guys are leaving an N0 axilla to start with without doing anything? So you've done a good ultrasound. Your sonologist tells you that the axilla is absolutely clean and clear, and this patient is ready for surgery. Now, do you still address the axilla, or you can leave it, or you can just watch out later
So
on?
those are
How
in
do
very, very selected cases, like very elderly patients with multiple comorbidities and a very clean axilla, small lump, or like, the lump is just to be removed so that like it improves the quality of life for the patient, very elderly patients, not for the routine like postmenopausal or never for the younger patients. We have not yet started leaving the axilla as such for a clinically node negative, even with ultrasound node negative axillas.
what do you routinely do in these patients?
It's a sentinel. If it is a clinically node negative axilla, the routine protocol at Delhi, like RGCI, is we get the imaging studies done. Most of the patients, they turn up with PET CT, and otherwise, if they've not turned up, they are early cases, then we get an ultrasound of the axilla done. If there is any node which is visible and which looks suspicious, or like there we get a FNAC of the axillary lymph node. If negative, then it is proceeded with the sentinel lymph node biopsy, usually like the dual dye technique or with the single ICG technique. So that is very well validated. So around 3 to 4 nodes are taken out, and then so basically the ICG alone also works very well.
Great.
Yes.
Kapil, you're around?
Yes, sir.
How are you, Kapil?
I'm fine, sir.
So do you have the facility of sentinel lymph node biopsy in your unit?
Yes, sir. I have facility for dual dye, and since last 3 months only. Earlier, it was not done because we have only single dye, but we are not following that sentinel. But now we are doing even 1-2 cases post NSCT also we did sentinel lymph node biopsy. But if your question in that scenario, if clinically not positive post NSCT, so still I'm confusing that we are doing only L and low axillary sampling.
Okay, so you mean to say that a patient who is N1 to start with and post NSCT turns out to be N0 clinically, you are doing a low axillary sampling on this patient in your unit.
Yes,
This is what you're saying?
in our center we all are doing say like that.
Okay,
But
great.
since we got that machine acrylic done, almost we hopefully in next few months we'll start something new like an SLNB post NSCT also.
Okay. Great. So we have the slide right in front of us, which tells us about two great trials. Again, one is the Milan trial, which was done from 1998 to 1999, and NSAP BP B32 again from 94 to 2004. Now, Milan trial, the selection of patients was patients who had less than 2 centimeter tumor, which was treated with BCS, who had negative sentinel lymph node on SLNB. So what these patients having in, some of them were offered ALND, some SLNB. Median follow-up was 3.8 years. There was no difference in overall survival or disease-free survival, and axillary recurrences were comparable. There was 0 in both the arms. So this was great. ALND versus SLNB. In NSABP B32, these were the patients who were treated with BCS or mastectomy. Again, negative sentinel lymph node, ALND versus SLNB alone. There was no difference in 10-year local recurrence rate or DFS or OS. And axillary recurrences were again comparable, less than 0.5% in both the arms. And in 61.4% of cases, the sentinel lymph node was the only positive node identified. So again, wonderful. Next one, please. Next slide. Next slide, please. So these are few trials for axillary management, and from 70s, early 70s to till today, the focus is on making it less and less on auxiliary management, less and less.
Excuse me, sir.
Uh,
Excuse me, sir. I'm sorry to interrupt. In interest of time, I would request you to kindly conclude in another 2-3 minutes.
I'll conclude it in 2-3 seconds if you want me, Avni. Okay, so these were wonderful trials, and I think in the best interest of time, the message which goes today right now in current scenario is uh, to reduce the morbidity post any sort of surgery in breast cancer patients. We are trying to minimize the invasive part on breast. The same is being tried on the axilla as well. The biggest, what you say, turning point was ZOO trial by Monica Moro, and these were, they identified a group of patients who were offered just axillary radiotherapy post sentinel lymph node biopsy for these patients who had some or other form of positivity in sentinel lymph node biopsy. So they could always leave without ALND, and they had comparable results long term. Now with the new CINOMAC trial or sound in CIMA trials, the emphasis is on to omit sentinel lymph node biopsy altogether in patients who are axillary N0 to start with. Anyhow, thank you so very much. We had a good discussion and a good panel, and see you soon again. Thank you so very much. Thank you.
Thank you, sir. Thank you, Uttam sir, for making this important topic so clear. And thank you all the panelists for participating in this and giving your inputs. So thank you, Dr. Sarika, Dr. Megha, Dr. Garima, Dr. Anand Mohan, Dr. Kapil Dev, and Dr. Jeevan Ram, sir. And now we will move to the next session, which is a panel discussion, and this is moderated by our dear colleague Dr. Siddharth Turkar, and he will be the topic of this panel discussion is management of the oligometastatic disease in the breast cancer. So Siddharth, please call your panelist, and we will love to listen your talk and the moderation. Dr. Siddharth is senior consultant in medical oncology department, Apollo Hospital, Mumbai. Yes, Siddharth.
So my slides is visible to everyone.
Sir.
Hello.
So no, it's not visible. Please share.
Okay.
Yes, sir.
Yeah, now
Yes.
it is visible.
Yes, sir. It is visible now. Go ahead.
Okay. So my topic is oligometastatic breast cancer, and my panelists are Dr. Ananya Parikh. Dr. Ananya, are you there?
She
Dr.
has not joined.
Sandeep Bhaskar. He's on. Okay. Dr. Rashi Agrawal. She is Director and Clinical Administrator, Radiation Oncology, Max Healthcare, Ghaziabad. Is she over here? Dr. Poonam Goyal, Consultant Radiation Oncologist. Dr. Poonam, are you there? Hello? Dr. Puneet Nagpal, Consultant Radiation Oncology, Metro Group of Hospital, Faridabad.
Yes, sir, I am here.
Okay. Dr. Deepak Uppal, Consultant Medical Oncology, Amar Hospital, Patiala.
Yes, sir, I'm here.
So I think Dr. Poonam, Dr. Puneet, Dr. Deepak are there. Rest three panelists are yet to join. So should we start, sir?
Yes, sir, please go on.
Yes.
Dr. Rashi is also there.
Dr. Rashi is also there. Okay.
Yeah.
Okay. So to start with, I just want to give a background. Oligometastatic breast cancer represent a specific condition where it is between a locally advanced disease, which is considered to be curable, and polymetastatic disease, which are considered to be non-curable. So when we are talking about breast cancer, it can be either early disease where the disease is definitely curative, locally advanced, and metastatic disease. There is a fourth category called as oligometastatic disease, and this entity was considered a separate entity since 1995. So we can divide oligometastatic disease into either de novo genuine oligometastatic disease, where at presentation only a patient has presented with oligometastasis. It can be induced oligometastatic disease, where a polymetastatic disease after systemic treatment is having oligometastatic disease. It can be metachronous, where on treatment patient has developed certain oligometastasis. So these are various definitions that are circulating, and it is still not very clear. So to start with, I want to ask my panelist, I want to ask my panelists whether they are what is their definition in what definition they are using in their clinical practice. Dr. Deepak, can you comment on that?
Yes, good evening, everyone. Sir, in our practice, either the metastasis number is less than or equal to 5, or 3 mets in a single organ system. And if we talk about the number of organs involved, it is more or less 3 organs. But this is the definition we use theoretically. Practically, we can change it according to the whatever the number of targets, lesions we can target or with the ablative therapies according to the biology of the disease.
So what definition basically you are using in your practice? So say suppose patient is
Sir,
having 6 metastatic disease.
3 to 5 metastasis and in single organ system less than 3 mets.
Or any organ is acceptable, whether it is liver, lung. In case of breast cancer particularly, I am asking.
Yes, sir.
Yes. What about Dr. Rashi? What is your view on that part from a radiation oncologist perspective?
I think I agree with Dr. Deepak. So we have to up to 3 to 5 metastases, and if we are able to ablate, so we proceed with this only.
Okay, so if rather than going for a hardcore definition, if you are able to ablate, then you would consider that as an oligometastatic disease. So now coming to that, does everyone feel that there is a role of loco-regional therapy at all? So as Dr. Deepak and Dr. Rashi has already told that they believe that this is a separate entity. Dr. Poonam, can you comment on this part? Dr. Poonam, Dr. Puneet, can you comment on this part?
Yes, sir. There is a definite role of loco-regional therapy in this oligometastatic disease because we will consider the aim of treatment as curative. So we'll take the loco-regional as well as the oligometastatic site and we'll try to ablate it.
You try to ablate it. So,
Yeah.
does anyone in the panel feel that because we are just delaying the progression in this disease, it is ultimately just a time where we have detected the disease just early, but ultimately it is going to metastasize. We are just delaying the progression. So, is there any panelist who think that oligometastatic disease is not curative intent, but we are just delaying the progression? Dr. Deepak?
Sir, we don't have a conclusive answer to that. Some trials we have the OS benefit, like Saber Comet
No,
trial
I
and
am not
other.
talking about OS or PFS benefit. I am just telling ki whenever you are treating a oligometastatic disease, whether even if you are giving a loco-regional therapy, are you giving it with the intent of curing the disease, or you are giving it for the sake of delaying the progression and improving the overall survival without considering it to be a curative
Sir,
intent? So that
that answer depends on many parameters, on the biology of the disease, and if it is a metachronous, on the disease-free interval, and many factors count. If it is
so you do consider that these diseases can be cured, right?
yes, sir. Yes, sir.
Yeah, yeah.
Since in some subgroup of the patients, yes.
In some subgroup of the patient, obviously we don't
Yes,
have
sir.
a definite idea about in which patient should we consider all these things. That's why we are discussing over it. But
Yes.
we do consider that this is a separate class where we can actually attempt the curative intent treatment. So when we are talking about oligometastatic breast cancer, we have already gone through the definition, and it is mainly a largely data-free zone, or we can say that there is mixed data where we have seen a certain benefit by adding the local treatment, and in certain trials we have not seen much of a benefit, and that's why there is the existing evidence is not very definitive in this area. So now coming to the role of primary local treatment. So any patient with a primary metastatic disease, if presented, like if a patient has breast cancer de novo and patient also has a liver metastasis and a single bone metastasis. So are we going to consider for surgical treatment alone if we are able to metastasize, or we think that radiation therapy can be given to a site where surgery is also possible? Uh, I want radiation oncologist to comment on that part. Dr. Rashi Agrawal, can you please comment? So I'm asking, if a patient has a single bone mets, a primary disease, and a liver metastasis disease, the surgeon, we have given the systemic treatment, and do you consider to give radiation to the disease site, or the surgery alone will be feasible?
So what we are following in our hospital, we are treating so many patients. So in these type of patients, we are doing radiation only. So I think the previous question of yours, in our mind, it is there. We are actually not curing the patient. We are just delaying. So if it would have been colon, so then would have opted for surgery. But in cases of breast, we are doing radiation. We are not targeting patients for surgery, or in bone mets also we are doing this. Yes.
So you are considering rather than going ahead with surgery only, you are giving the option of giving radiation to reduce the surgical process. Okay. Again, to the question to the medical oncologist, if you treat such patient, you are giving the chemotherapy. So will you call that as an adjuvant chemotherapy? So how long are you trying to give such kind of chemotherapy? Dr. Deepak.
So if the intent is
If the disease
curative,
is suppose hormone receptor positive, so you know that we have trial of adjuvant abemaciclib, and considering the disease was oligometastatic, so you are going to consider it till progression, or you are going to give it for the limited period of time?
sir, we don't have a conclusive evidence for that, but considering it is oligometastatic, we will consider it till progression.
Till progression, you are going to continue that. Okay. So based on various bodies, oligometastatic disease, as I have already told, is being defined up to 5 metastases, and in some definition they have said it regardless of the organ involvement, and they have defined it like that. Or in some definitions they have told it like if we can give local treatment to all the part, then we can consider that as an oligometastasis for up to 5 metastatic sites. So there are various ongoing trials to answer the precise questions that we wish to get, that whether we are treating with curative intent or we are just delaying the progression, or is there any real benefit with local treatment considering so many systemic treatment options. So again to Dr. Deepak, so these are the parameters you can see on the screen. these we have discussed that do you think that these three parameters are acceptable whenever we are considering the metastatic breast cancer? That all lesions are resectable, including primary? There are three options. What would you consider as an oligometastatic breast cancer in your practice?
So mostly if the all lesions are resectable and surgeon is comfortable in doing the surgery for all the lesions, then primarily the surgery is preferred. But considering the bone metastasis, the most frequent one, then in that case is the local ablative radiation is preferred.
Okay.
And along with the surgery for the primary.
So regardless of the only surgery can be considered or radiation, you are going to consider that as oligometastatic. Dr. Puneet, for you, how you are going to designate the oligometastatic based on our discussion what we have till now?
See, oligometastatic breast cancer after systemic therapy, if there is a good response and the breast lesion is amenable for surgery, and there are other lesions also like bone lesions where there is decrease in SUV or decrease in size, and single metastasis is there, and the surgeon is comfortable in resecting the primary, then I'll go with resection of the primary followed by radiation, ablative radiation to the metastatic sites. If the surgical resection of metastasis is possible without any harm, then if the surgeon is willing to perform, then it should be preferred. And then,
so in your practice, suppose a patient presented with more than 6 metastasis, it was considered to be polymetastatic at presentation. Then
yes,
after giving the systemic treatment, the only 1 or 2 sites are left, rest the patient has complete response. Do you consider that patient as a oligometastatic disease? Because according to certain definitions, it can be considered as an induced oligometastatic disease. So do you
yes.
consider that as a oligometastatic?
Yes, various parameters like if the patient is ERPR positive and patient has good further therapy also. So yes, patient can be considered for as an oligometastatic disease.
Even if the patient is presented as polymetastatic.
Polymetastatic. Yes,
Yes.
we can give a try.
Okay. So, is there any preference for certain biology to be considered as a oligometastatic? Dr. Poonam, uh, can you answer this question? Is there any subtype that you are not going to consider for oligometastatic, like triple negative or HER2 positive or ERPR positive, or you are going to consider all as oligometastatic disease? Dr. Poonam, I think, is not there. Dr. Deepak?
So regarding the subtypes, basically we consider all the types as oligometastatic, but TNBC and HER2 positive disease tend to do worse with the curative intent on the oligometastatic disease. So if you ask me that what I will be comfortable in with treating a curative intent, that will be strong ERPR positive and HER2 negative disease.
Okay, okay. Do you use any biomarker to know whether to decide on the treatment algorithm, whether to go ahead with local treatment or not?
Sorry,
Like
one is the
ctDNA or some tumor marker or something like that?
yes, sir. ctDNA, first are the histological biomarkers, then are the ISC-based biomarkers that we used, ERPR and HER2 and Ki67 or the grade of the tumor. Now we have the role of ctDNA is emerging. But till now, I have not included that in my practice to use the ctDNA as a biomarker for a oligometastatic disease. But yes, it is there. Or
It is
even
there. So you
PIK3CA
believe that it
mutations
is
and all
going to
that.
have a role on that part?
Yes, sir.
Okay, okay. So I will just share a case. So this is a 48-year-old female lady with no comorbidities. She has to begin with CT4B N2 disease, and there was mediastinal lymph nodes present. You can see the PET-CT report on the screen where there was a disease in the mediastinum and there was a lytic lesion in the sternum. So and the patient was ER/PR positive and HER2 negative. So based on our discussion, Dr. Deepak, would you consider this as oligometastatic disease? Because as per the definition, the patient has less than 5 metastatic site, and it is ER/PR positive also. So,
Yes,
doctor,
sir.
you are going to
Yes, sir.
consider it.
This will be considered as a oligometastatic.
So, would you consider to get a biopsy from the oligometastatic site to confirm whether it is really a metastasis, or is it something else?
Yes, sir. The mediastinal lymph node per se are many times doubtful, and most of the time it is infective pathology that is having the uptake, inflammatory or infective. So, if it is possible, yes, we will. I would like to have a biopsy from the mediastinal lymph node, subcarinal lymph node.
Subcarinal lymph node. So this was done in this patient, and this patient was on biopsy was found to have metastatic carcinoma in the background of a necrotizing granulomatous inflammation suggestive of tuberculosis. So, but the AFB stain and TB gene expert was negative. So, as you have suspected, this patient was found to have uh, uh, a dilemma regarding whether it is tuberculosis related. But again, because the disease was also there in the sternum, we have considered this patient as oligometastatic site. So, how you are going to approach this patient, Dr. Puneet? Can you please comment on that part?
So, being clinically T4B and 2 with the subcarinal metastatic lymph node, so we'll start with the systemic therapy, and
Systemic
then
therapy.
yes, and then
So, say
we'll,
suppose patient has responded well to the systemic therapy, then what will be your complete treatment plan if the patient has responded?
if the patient has responded well and the subcarinal node has reduced in size, along with that, the primary has also reduced, because she is having ER/PR positive, strong positive, HER2 new negative with no comorbidities. So the intent should be, if it is a good response, the intent should be curing this disease and
So,
progressing
you are
further.
going to consider for neoadjuvant chemotherapy,
Yes,
and if the patient is responding, you are going to follow the full treatment protocol of a curative intent
yes,
patient.
yes, yes.
Dr. Deepak, you are in coherence with that part?
Yes, sir. This case should be treated with the first the
Curative
neoadjuvant
intent.
systemic treatment,
Okay.
followed by the curative treatment for the local.
So, as
The incidence for that is the evidence for that is maturing, sir. But as of now, I will use the neoadjuvant systemic chemotherapy.
systemic chemotherapy only.
Yes,
Okay.
sir.
Okay. So this patient was treated with a neoadjuvant chemotherapy with dose dense AC followed by paclitaxel to get the best response, and then patient was reassessed with PET-CT. As you can see, the patient had a response in most of the areas. Only there was interval increase in size and metabolism of mediastinal lymph nodes. So again, because this patient has only not responding in that particular area, would you consider rebiopsy to see whether there is something different in this part, or do you think that we should not consider local treatment in this patient?
Repeat
Uh,
biopsy.
Repeat biopsy, Dr. Rashid. Okay. Okay. So we have done the repeat biopsy and it was came out to be AFB positive and gene expert positive, because there was a dilemma in the upfront that it might be a tuberculosis. So that's why we have done it again, and we have started on anti-tubercular treatment. And as all panels agree, we have started. Patient underwent surgery. So
So, I'm sorry
yes,
to
yes,
interrupt.
yes. So, like, I will just finish in 5 minutes. Just
Okay,
give
sir.
me
Okay,
five
thank
minutes.
you.
Okay. So, again, this is very important point that in country like India, where TB is endemic, and you have seen that patient might many times we see that patient come out to be positive in subcarinal lymph node. So, do you think that PET-CT is an optimal modality? Or do you think something else should be done, or something lesser like CT scan is a better way to define on that part? Dr. Rashi, can you comment on that part?
So see, PET CT, it become necessary in our country. Either you advise or not advise, it will happen. So I think we should use our biopsy properly. We can use that as you have done in this case.
So in your routine practice, are you doing biopsy in every patient?
We are trying to do this. In this case, it happened, the size of node has increased. What we
Okay.
have thought, it has not happened. Then we advise patient to do that biopsy and we do it.
So say suppose patient has a primary breast lesion and a liver metastasis. So are you going to biopsy the liver lesion at upfront setting, or you don't do it if it is radiological compatible with the metastasis?
No, we do. Actually, in our setup, interventional radiologist is very good. So there is
Okay,
no
so if
problem
you
with
are
us.
considering oligometastatic disease, you are doing a biopsy of every lesion.
If it is easy to do, and if you think ERPR positive, T1 stage and liver mets is there, we can do, and we do it.
Okay. Okay. So
Ideally, if sorry, I'm interrupting.
yes, please.
Ideally, if it is feasible, then oligometastatic site should be FNAC or biopsied. Each and every site should be done.
Okay, okay. So that's what I agree. And based on this article, that if we do only CT scan, around 50% of the patients get upstage to stage 4 from stage 2B to 3 cancer. So that's why it is very necessary that we do PET CT. There is some newer modalities like FES PET CT, which can detect estrogen positive metastasis and can better differentiate than a FDG PET CT. So I would just try to wrap up. So any comment regarding triple negative breast cancer? So because in this NRG trial which was recently done, it was the triple negative breast cancer patient has not fared well as compared to the hormone receptor positive. So do you consider that triple negative breast cancer we need not to be that much aggressive as compared to the patients who are hormone receptor positive? Anyone can comment, please.
Earlier when you said that we are delaying the progression or we are treating with curative intent. If it is a TNBC young patient, then yes, the oligometastatic after oligometastatic, we are just delaying the progression. And if it is a ERPR good biology, then yes, we can treat it with curative intent. So patient selection is a very, very
So
important.
that is based on the treatment response rather than the
Yeah.
only on the biology.
Yes.
So all panelists agree on that part. So regarding the brain metastasis, if the patient has brain only metastasis, I just want a quick comment on that part. So are we considering are we considering the surgical metastatectomy, or we are considering whole brain RT or SBRT in these kinds of patients? What is your routine practice, Dr. Rashi?
If it is periphery surgery in this case, periphery located, it can be easily possible. So
Okay.
then we are going for surgery, and WBRT to no, never.
Okay.
Not
So
the
WBRT you are not considering, you are just considering the surgery
surgery or
only.
SRS. If surgery, you think after surgery there are chances of if the surgery, patient is having deep lesion.
Okay,
We
okay.
are thinking only biopsy is possible, then we don't do. If surgery can be good, then we go for surgery.
So based on the evidence, you can see in this forest plot of in this meta-analysis that compared to WRT and radiosurgery, the WRT and radiosurgery fared well than WRT, and when we have seen only radiosurgery, it has also WRT has not benefited, and the patient has worse cognitive outcome when we are giving WRT to all the patients. So as Dr. Roshi has pointed out, that if the disease is not polymetastatic in the brain and we can target the lesion, then we should consider a targeted radio surgery kind of an approach. So again, this I just want to summarize this SABR COMET trial, in which there was some overall survival benefit in those patients who have undergone a local SABR, but only 18 patients was there, and that's why the strength of evidence is not that hard, and we don't know whether the benefit to the breast cancer patient is going to be there. This is a recent trial which was presented in 2022, and it doesn't show much benefit with local treatment when added to the systemic treatment. You can see on the progression-free survival curves, it is almost overlapping, and the results hazard ratio was not significant. Again, overall survival arm has not done that much good. But still, we believe that if we have better patient selection, because in this study they have pointed out that those patients who have triple negative breast cancer do worse than those who have hormone receptor positive disease. So maybe if we are considering only hormone receptor positive disease, then we could have a better overall survival when we are adding the local treatment. So this point also we have already covered, that if we are treating with curative intent, if we are treating oligometastatic disease, Dr. Deepak has commented, we are generally considering to give the hormonal treatment and targeted therapy as long as possible if the patient is responding to it, because we are practically delaying the progression.
Sorry to interrupt you, sir. We are running short of time.
Just
Please.
I am just going to conclude my slide. Okay.
Yes.
So there are various trials that is happening, and with the advent of better and better systemic treatment, the point that we are delaying progression with local therapy, maybe at a point, at certain point, we may think of just delaying the progression with the help of better targeted therapy and reduce the toxicity to the patient. That is one kind of point of view that is being shared that is being commented by many of the experts. So that's what we can consider. But till that, we don't have much of a data. We still have to discuss all these cases in multidisciplinary meeting and treat case by case basis, and think about the curative intent even in these kinds of metastatic disease, because they can have a better survival when we are adding the local treatment. Thank you.
Thank you, Dr. Siddharth, for your very nice panel discussion and moderation. So thank you very much. Thank you all the panelists, Dr. Deepak Uppal, Dr. Rashi, and Dr. has joined, Dr. Puneet Nagpal, and Dr. This one. Yeah, so all the panelists. Now I will move to the panel discussion, which was set to be in the little different time, but Dr. Manish Gautam has some emergency, so he wants to present early. So the next topic of discussion and you can say the presentation is response-driven management of hormone HER2 positive EBC that is fueled by updated data of TDM1. So Dr. Manish Gautam is medical oncologist in Kota, Rajasthan. So he will be speaking on this topic. Welcome, Dr. Manish. Dr. Manish? Sakshi, can you ask Dr. Manish to join?
Yeah, sure.
Is there? Dr. Manish Gautam has joined. Dr. Manish, please unmute yourself. If somebody is connected with Dr. Manish? Sakshi? Nishant?
Sir, Dr. Manish Gautam is not available right now. We can go with Dr. Ankit Agarwal.
Okay, so Dr. Ankit, my good friend. So Dr. Ankit is speaking on a sponsor session. sponsored by AstraZeneca. So his topic of discussion is trastuzumab deruxtecan for the treatment of hormone receptor positive HER2 low positive MBC and hormone receptor positive HER2 ultra low. This is the recent topic and it needs much discussion to change our practice. So Dr. Ankit Agarwal, over to you. Please enlighten us.
Thank you, Asim sir. Thanks a lot. It has always been wonderful sharing the same platform with you, and I thank you for
Same here.
giving me this opportunity. So we are running short of time, I think, so we'll not waste further time. And it's a very interesting topic that has been given to me, and it's the slides have been provided by Astra. So we'll just go ahead with the discussion about the topic. So what we are going to discuss in the next 15 or 20 minutes uh, is a recently updated scenario that has changed our practice, the way we look at a HER2 negative disease. It has come as even in that patients we can use a targeted therapy. So TDXD has come into picture by managing these kind of patients. So this is the overview. We'll discuss about the introduction and background, the unmet need in hormone receptor positive and HER2 negative metastatic breast cancer, the NR2 TDXD, that is TDXD mechanism of action. We'll discuss in detail about the Destiny Breast 06 study design, the efficacy, safety, and health related quality of life data, and the details about TDXD. We'll discuss about the adverse effects management guidelines, specifically pertaining to nausea and vomiting and interstitial lung disease. And in the last few slides, 2 slides, we'll discuss about the summary and guideline recommendations. So, starting with the introduction and background, as we have already been treating our patients on the basis of immunohistochemistry when it comes to any form of breast cancer, whether it is metastatic or whether it is curative intent. We have been treating our breast cancers on the basis of immunohistochemistry, IHC, that is ERPR and HER2. And apart from all the patients who had HER2 plus 3 on IHC, and those who had HER2 plus 2 on IHC with a FISH positivity, all the patients were considered as HER2 negative, and these were the patients wherein the guidelines suggested that trastuzumab could never be used or pertuzumab could never be used in these kind of patients. But now the recent guidelines have suggested that among these patients who are basically were initially described as HER2 negative, that is HER2 1 plus, HER2 2 plus with a FISH negative reports, among them around 60 to 65% of the 65% of the cases who were HER2 negative initially, they turn out to be HER2 low, that is IHC 1 plus or IHC 2 plus with a FISH negativity. Around 10 to 15% of the cases, they are IHC 0 with a low or with a ultra low or an absent membrane staining. Ultra low being 20 to 25% and absent membrane staining being 10 to 15%. That means out of the patients who were actually HER2 negative, initially the real people who were not eligible for any targeted therapy are only 10 to 15%. And apart from these 10 to 15%, all the other 80 to 85% of the cases are the candidates to receive TDXD. This is what we are going to discuss, how TDXD has changed the treatment landscape for these patients who were initially HER2 negative on IHC, and now they are either low or ultra low as per the recent nomenclature. Now this is what Destiny Breast 06 has done. It has targeted low and ultra low HER2 expressing tumors in metastatic breast cancer. So we all have recently started using this new nomenclature of HER2 null, HER2 low, HER2 ultra low, and HER2 positive. HER2 negative has almost become we are not using it anymore in our discussions routinely. So all those patients who were initially HER2 2 plus and FISH negative or IHC 1 plus have all been categorized as HER2 low. Those patients who have faint or incomplete membrane staining in less than 10% of the tumor cells are called as HER2 ultra low. If on IHC you do not see any kind of membrane staining, then it is called as absent membrane staining, or the new nomenclature is HER2 null. So this is where this is the area HER2 low and ultra low, wherein the Destiny Breast 06 has shown that we can use TDXD even in these category of patients. So what is the unmet need in hormone receptor positive and HER2 negative metastatic breast cancer? We all know that when a patient comes to us with a hormone receptor positive and a HER2 negative metastatic breast cancer, the current treatment landscape suggests that if you give CDK4/6 inhibitors with the endocrine therapy, it has provided a significant overall survival benefit as compared to endocrine therapy alone, and it has also shown it is better than using the treatment of physician's choice, that is chemotherapy, if a patient has turned out to be hormone receptor positive. But as these patients progress, and once we are once we have consumed 2 lines of therapy, the third line agent is wherein TDXT comes into picture. If the patient is HER2 low or ultra low, that is where the TDXT has come into picture. Also, TDXT has shown a promising median progression-free survival and overall survival, especially in certain poor prognostic patients like those who have primary endocrine resistance. If a patient has progressed within 6 months of your endocrine therapy, and that means the patient has primary endocrine resistance, this is where also TDXD has given a substantial median progression free survival benefit over the treatments of physician's choice, that is chemotherapy, either be it capecitabine or taxane. So coming to the TDXD in detail, what is the mechanism of action of trastuzumab deruxtecan? It is basically a monoclonal antibody that is linked to a highly potent topoisomerase 1 inhibitor payload, the ratio being 8:1. That is, the drug to antibody ratio is 8:1. The tetrapeptide based cleavable linker is what it links the payload to the monoclonal antibody. Once the TDXT being a trastuzumab, being the monoclonal antibody being trastuzumab, it gets attached to the HER2 protein or the HER2 receptors, and then it is internalized in the cells, tumor cells. So once internalized, the linker is cleaved, that releases the payload, that is a topoisomerase 1 inhibitor, and it enters the nucleus. Once it enters the nucleus, it causes disruption of the protein synthesis, disruption of the DNA, and cell death. One more interesting thing about TDXD is the bystander effect that we see. It is called as the bystander anti-tumor effect. Now, because this payload, that is topoisomerase 1 inhibitor, is membrane permeable, what it does is, once it enters the nucleus of one cell, it also has the tendency to cross over to the another cell because it is very much cell permeable, and thus it leads to killing of the neighboring cell also, which is called as a bystander anti-tumor effect. So the Destiny Breast 06, what is the study design? It was an open label randomized multi-center phase 3 study wherein the patient population was hormone receptor positive metastatic breast cancer, which were either HER2 low, that means IHC 1 plus, or IHC 2 plus with FISH negativity, or HER2 ultra low, that is IHC 0 with less than 10% membrane staining. They should be chemotherapy naive in the metastatic breast cancer setting. They should have received at least 2 lines of prior endocrine therapy with a targeted therapy for metastatic breast cancer, or at least 1 line for metastatic breast cancer, provided they should have progressed within 6 months of the first line endocrine therapy and a CDK4/6 inhibitor, suggesting they should have primary endocrine resistance in the metastatic setting, or if they were used, the endocrine therapy was given in the adjuvant setting, they should have progressed within 2 years of starting adjuvant endocrine therapy, again suggesting that these are poor prognostic populations having primary endocrine resistance. They were randomized into 2 arms, the TDXD arm, wherein TDXD was given at 5.4 milligram per kg every 3 weekly. The second arm was the treatment of physician's choice, wherein capecitabine, nab-paclitaxel or paclitaxel was given to the patients. The primary endpoint was progression-free survival by blinded independent central review in HER2 low disease. Key secondary endpoints were PFS and overall survival in HER2 low and HER2 ultra low. This was the demographics and key baseline characteristics, well matched between the two arms. We will not go into the details of the baseline characteristics. Now, as you can see, the number of patients who had HER2 low disease was around 66%, versus those patients who had HER2 ultra low was around 20%. So this was the ratio that was seen between in the demographics in the Destiny Breast 06 trial. Most of the patients had received at least 2 lines of treatment before initiation of TDXD. Around 67% of the cases received at least 2 lines of treatment before starting TDXD. What was the efficacy, safety, and health-related quality of life data at the and what are the trial results? Now coming to the progression-free survival in HER2 low strata, this was the primary endpoint. When TDXD was given to these patients, it showed a median progression-free survival of 13.2 months versus a median progression-free survival of 8.1 months in the chemotherapy arm. Difference of 5.1 months, suggesting a hazard ratio of 0.62, 38% reduction in the risk of progression when TDXD was used as compared to chemotherapy. It shows a significantly improved median progression-free survival in HER2 low setting. All those patients, PFS in the intention to treat population also almost similar, a 0.64 hazard ratio, 36% reduction in the risk of progression when TDXD was given as compared to treatment of physician's choice. Coming to the overall survival data in the intention to treat population and in the HER2 low and HER2 ultra low both combined, when we talk about HER2 low, the 1-year survival, that is a 12-month OS rate, was 87.6% in the TDXD arm with a hazard ratio of 0.83. Now, the important point to consider is around 20% of the cases in the treatment of physician's choice group had crossed over to the TDXD arm post-treatment discontinuation. Probably that might be one reason why the OS difference is not very high. Similarly, in the HER2 low and HER2 ultra low, both together combined, the 1-year OS difference was 87% versus 81%, and around 18% of the patients in the treatment of physician's choice group had crossed over to the TDXD arm. It also demonstrated a consistent median progression-free survival benefit across the pre-specified exploratory subgroups. As you can see, this is the forest plot. Of all the subgroup analysis, you can see TDXD was favored as compared to the treatment of physician's choice. Interesting thing to look for is those patients who had a primary endocrine resistance, the hazard ratio was 0.56, suggesting a 44% reduction in the risk of progression when it was used in those patients who had a primary endocrine resistance. So, a poor prognostic population who have a primary endocrine resistant population, TDXD has done wonders. PFS and OS in HER2 ultra low also, it was consistent with the results in HER2 low, hazard ratio of 0.78 for progression-free survival and hazard ratio of 0.75 for overall survival. Progression-free survival median was 13.2 months in TDXD and a 1-year OS rate was 84% when HER2 ultra low patients were analyzed. Coming to the overall response rate, 56% of the patients had an overall response when TDXD was given as compared to 32% of the cases who responded to the chemotherapy. Around 2.5% of the cases responded completely. They had a complete remission. Partial response was seen in around 54% of the cases. A clinical benefit rate of 76.6% was seen in TDXD arm. Coming to progression-free survival by the time to progression. Now, irrespective of the time to progression, whether the patient initially had progressed within 6 months of endocrine therapy or 6 to 12 months of endocrine therapy, or it was more than 12 months, TDXD had consistent benefit over the treatment of physician's choice. Coming to the second progression-free survival, even second progression-free survival was higher in the TDXD arm in the intention to treat population. The median progression-free survival 2 was 20 months in the TDXD arm versus 14.7 months in the treatment of physician's choice, with a hazard ratio of 0.62, significant. As you can see, the p-value very significant. PFS measures by disease burden. Irrespective of the disease burden, TDXD had shown a significant benefit over treatment of physician's choice, although the forest plot suggested that those patients who had a low disease burden, the TDXD arm showed a better benefit, although it was significant in both the scenarios. Coming to the safety, I think that is the concern for most of the clinicians who want to use TDXD in their setting or who have already used TDXD. Now, the treatment emergent adverse effects of any grade were seen in around 98% of the cases in TDXD arm, and the grade 3 side effects were around 52%. Around 14% of the cases had to discontinue treatment because of the treatment emergent adverse effects. Around 24% had dose reductions because of the TDXD related to TEAE. Now, the most common TEAE, that is treatment emergent adverse effects, which led to treatment discontinuation, was 5.3% associated with pneumonitis in TDXD arm, 1.4% associated with peripheral sensory neuropathy in the treatment of physician's choice arm. Most common treatment emergent adverse effect that was associated with dose reduction was nausea in the TDXD arm and hand-foot syndrome in the treatment of physician's choice arm, that was 16.5%. Coming to the safety profile in the Destiny Breast 06 versus Destiny Breast 04, as you can see, the safety profile was the same between Destiny Breast 06 and 04 trial. 04 basically had included only low patient, low, not ultra low. Now, there are few adverse events which are of very special interest to all of us as clinicians. The first adverse effects that definitely needs a mention is the interstitial lung disease. Now, in the Destiny Breast 06 trial, around 11% of the cases had any grade of interstitial lung disease, out of which 0.7% had grade 3. Most of the patients had grade 2 interstitial lung disease, which was manageable by low dose of steroids. The median time to onset of ILD was 142 days. Of the 49 patients who had any grade of ILD or pneumonitis in the TDXD arm, 20 of them were reported to have been recovered. 2 were reported to have recovered with sequelae. And in the treatment of physician's choice, interstitial lung disease occurred in 0.2% of the cases which was a grade 2 event. Coming to the cardiac toxicity, ejection fraction, decrease in the ejection fraction was seen in around 8% of the cases, most common being grade 2. The quality of life data also suggests that there was a significant improvement in the health-related quality of life, or you can say the health HOL was maintained throughout the treatment by NH2 as compared to the chemotherapy arm. To conclude, TDXD demonstrated a statistically significant and clinically meaningful PFS benefit versus treatment of physician's choice in hormone receptor positive and HER2 low metastatic breast cancer in an earlier line of treatment as compared to Destiny Breast 04. The results in the HER2 ultra low were also consistent with HER2 low disease. Confirmed overall response rate was seen in 57% of the cases with a clinical benefit rate of around 75%. So, Destiny Breast 06 establishes TDXD as an effective new treatment option for patients with hormone receptor positive, HER2 low and HER2 ultra low metastatic breast cancer following more than equal to one endocrine based therapy. So, this is the median PFS, 13.2 months versus 8.1 months in HER2 low and 13.2 and 8.1 again in those patients who had in all the patient ITT population. Last few slides, I think, although they are last, but very, very important, how do we manage the adverse events as soon as we see it, and what are the precautions that we take when we give NH2. So NH2 is basically considered as a highly emetogenic drug. So it is recommended that prophylactic antiemetic medications as per highly emetogenic chemotherapy should be given prior to any use of NH2, which comprises 3 drugs, 5-HT3 receptor antagonist, NK1 receptor antagonist and dexamethasone. Please do mind that steroid should not be given after NH2 has been administered. Rather than on the day 2 and day 3, you can give oral NK receptor antagonist if you have given oral NK receptor antagonist in the prior to NH2 administration. Now, real-world study also suggests that a 3-drug antiemetic regimen is a better controller of nausea vomiting induced by TDXD as compared to a 2-drug antiemetic regimen. Coming to the precautions and symptom identification for ILD. Now, there are certain key symptoms which need to be seen which need to be sought after whenever you treat any patient.
One of the research guide, and back then
Sorry. Okay, so there are certain key symptoms that need to be identified or need to be sought after, and the clinician should be very prompt in diagnosing these symptoms, such as new onset cough, new onset dyspnea, fever, or new or worsening respiratory symptoms are very important indicators to detect ILD very early or ILD at an earlier stage. Patients as well as healthcare physicians should be aware of the risk of ILD or pneumonitis and to promptly identify and report symptoms in order to initiate appropriate management. So these are the guidelines and recommendations. How do we manage ILD? So basically, ILD has been classified as grade 1, grade 2, grade 3, and 4 and 5. Now, grade 1 is basically patient does not have any symptoms, but it is seen on imaging. So what you do is, first of all, the moment you imaging suggests a ILD, NR2 should be stopped, it should be interrupted. NR2 can be resumed if the ILD is fully resolved to grade 0. If the ILD is resolved to grade 0 within 28 days from the onset, the same dose can be given. If it requires more than 28 days for the resumption to grade 0, the dose should be reduced by one level. And if it takes more than 18 weeks for the ILD grade 1 to resolve to grade 0, it is an indication to permanently discontinue NR2. The moment you see ILD grade 1, it should be monitored. Patient should be monitored closely, follow up every weekly from the day of onset for clinical symptoms and decrease in SpO2. Consider follow-up imaging. We routinely do imaging in every 2 to 3 weeks for a patient who has already having grade 1 ILD. Otherwise, baseline imaging, we get it done once in 6 to 9 weeks. Consider systemic steroids in case if the patient has, it can be considered if you want the symptoms to resolve early, if the treatment needs to be initiated on an urgent basis. Coming to the grade 2 ILD, grade 2 is basically patient has started showing mild symptoms and imaging is positive. So grade 2 and further, if ILD is seen, that is an indication to permanently discontinue NR2. Any grade 2 ILD, this is an indication to promptly start systemic steroids, 1 milligram per kg per day of prednisolone or equivalent for to be given for at least 14 days, and then gradual taper off for over a month. Symptoms should be monitored closely. Patient should be re-imaged again after 3 to 4 weeks, and dose can be increased to 2 mg per kg per day if the patient do not show signs of improvement. Coming to grade 3 also is an indication to stop or permanently discontinue NR2. Grade 3 requires IV treatment by methylprednisolone, a pulse therapy of 1 gram per day for 3 days, and then you can switch over to an oral omnacotil or oral prednisolone, 1 milligram per kg per day, tapered off in the next 4 weeks. CT imaging to be done every 3 weeks to see for improvement. Patient should be hospitalized and managed as per the response. Any suspected drug-related ILD should be monitored closely by respiratory system examination, pulmonary function test, oxygen saturation by pulse oximetry, especially oxygen after exertion, and high-resolution computed tomography. Regular assessment and patient education is the key for early identification, and it definitely requires a multidisciplinary team work to manage the side effects properly. This is the guideline recommendations. We have seen that TDXE has outperformed the chemotherapy in the Destiny-Breast 06 trial with a primary endpoint median PFS of 13.2 months versus 8 months and secondary endpoint of and overall response rate 56% versus 32%. Efficacy in the exploratory HER2 ultra low also was consistent with the HER2 low metastatic breast cancer patients. So all those patients who fit into the profile of HER2 low or HER2 ultra low, and especially if they have a primary endocrine resistance, should be offered TDXD to provide the best benefit and the best median progression-free survival.
Dr. Ankit, sorry to interrupt you. We are running short of time. Please conclude.
30 more seconds. 30 seconds. Thank you. So this is the ESMO guidelines. It has recommended that if a patient has progressed on HER2 hormone receptor on endocrine therapy, that is the first line endocrine therapy. The next treatment should be offered is TDXD if the patient falls into the category of HER2 low or HER2 ultra low. Even NCCN has recommended the same, and I think we all know about the guidelines currently. And I think that's all from my side. And I thank the organizers for having me here. Thank you.
Thank you, Dr. Ankit, for the nice presentation. The only problem with the utilizing this drug is ultra low and low. How to find it out from the pathology department is the biggest problem right now, but we will sort it out in the future. And really, it was a nice talk. Thank you very much, Ankit.
Thank you,
And
sir.
yeah, so now I would call the next panel discussion for this. Dr. Vikas Talreja is here. Dr. Vikas Talreja is Senior Consultant in the Medical Oncology Department, Regency Hospital, Kanpur. And the panelist, I would just introduce him. Dr. Mukesh Rulania. He is Assistant Professor in Medical Oncology and Hematology Department, State Cancer Institute, SMS Hospital, Jaipur. Dr. Pramod Kumar. He is Assistant Professor in Department of Medical Oncology, AIMS, Jodhpur. Dr. Abhishek Sharma, Consultant Medical Oncologist, Goyal Hospital, Jodhpur. Dr. Rahul Kumar Rai, he is medical oncologist in Jeevan Raksha Hospital, Bikaner. And Dr. Subhash Berwa, he is a consultant medical oncologist in JNU Hospital, Jaipur. So, Dr. Vikas, you please start your panel discussion. Over to you, Dr. Vikas. Yeah, Dr. Vikas.
Can anyone call? Sakshi, can you call, sir?
No, he has joined. So I
Yes,
guess.
so he has joined. He's not, I think he has to unmute. Vikas, sir. Can you hear us, sir? Sakshi, just call once.
I called him.
He's joined. He has joined. He's not like he has to unmute himself. Just tell sir like this.
Meanwhile, somebody can share the slides.
Okay, sir.
Ma'am, Dr. Vikas not picking my call.
Okay, I'll tell Tarun, sir.
Cool, yeah, just a minute. Huh? Okay, we have not connected with him. So can we have the talk of Dr. Manish Gautam before he comes? And Dr. Manish is there?
Yes, sir. Yes, sir. I am available.
Yeah, so please, you can start your talk. And this, you will be speaking on response-driven management of the HER2 positive EBC fueled by the updated data of the TDM1.
Yes, sir.
And it is sponsored by the Zydus. Yeah, Manish, you can start now.
Yes, sir. Yes, sir. Kindly attach the slides, madam.
Sure, sir.
Thank you, Asim sir, for inviting me here. And yes. So today we will discuss response-driven management of HER2 positive early breast cancer, fueled by updated data of TDM1 also. Next slide. So as we already know that the evolution of the HER2 targeted therapies in breast cancer बहुत पानी बह चुका है और वहाँ बहुत आगे आ चुके हैं. And starting in 1998, the first drug was discovered, trastuzumab, and thereafter in 2006, initially it was planned for metastatic disease, but in 2016 it has been approved for the adjuvant setting also. Thereafter, lapatinib, then in 2012, pertuzumab in metastatic setting, and later on in neoadjuvant and adjuvant setting in further years. Then in 2013, another drug TDM1 was discovered for metastatic disease, anti-HER2 as anti-HER2 therapy, and then neratinib, and in recent years, in 2020, tucatinib has been discovered. Next slide. Next slide. So, as we know that trastuzumab has been approved for well control of the breast cancer in anti-HER2 therapy, and adjuvant trastuzumab improved disease-free survival and overall survival for patients with HER2 early breast cancer also. These are the trials: HERA trial and NSA-BP-B31 trial and BCI-RG006 trial has been all shown the efficacy of trastuzumab in adjuvant setting too. So treatment with the adjuvant trastuzumab after chemotherapy is associated with significant clinical benefits, as we all see in this slide. Next slide, please. But we also know that the risk of recurrence still need to be minimized in HER2 plus early breast cancer. Next slide. Especially the patient who are high risk HER2 positive early breast cancer. Those are patients with HER2 positive EBC who have risk of more than 10% recurrence. After appropriate neoadjuvant chemotherapy and anti-HER2 therapy, if any residual disease present and non-pathological complete remission is if present, or either after surgery first and any node positive disease, or T3 or T4 disease with NEN. So these patients need escalated adjuvant therapy to salvage the risk. Next slide. So how can we personalize our approach to reduce the recurrence rates? Next slide. Further development of other therapies required after trastuzumab, and already has been discovered neoadjuvant therapy move towards personalization. So when we use neoadjuvant anti-HER2 therapy, response can guide us to improving the outcomes. So if there is complete pathological response, then we can continue the same trastuzumab based anti-HER2 therapy for 1 year. But if any residual disease, even lesser residual disease is present, then we can escalate our therapy. Next slide. Because we all know that if high risk breast cancer anti-HER2 patient, despite using single agent trastuzumab, recurrence rate is high because micrometastasis is present. So HER2 new positive breast cancer patients with residual disease have poor outcome, as we all know. And this graph showing that association of PCR with better early EFS and hazard ratio is 0.31. With PCR, there is the difference 5 years. And this DFA overall survival also showing this differentiation of curve, and it need escalation of the adjuvant therapy for the residual disease. Next slide. Need of response adapted adjuvant therapy in HER2 positive breast cancer, especially for residual disease group. Next slide. So how can building on the trastuzumab, additional anti-HER2 therapy is required, and all are approved in the adjuvant setting by various trials. TDM1 was FDA approved in May 3, 2019 as adjuvant therapy for patients with the HER2 positive early breast cancer and residual invasive disease after neoadjuvant taxane and trastuzumab based treatment. Another medicine or combination of trastuzumab along with pertuzumab, and it has been approved by FDA in December 2017, and it was used in combination with chemotherapy as neoadjuvant treatment of patients with the HER2 positive early breast cancer, either more than 2 centimeter T2 tumor and N positive tumor, and adjuvant treatment of patients with HER2 positive early breast cancer at high risk of recurrence. So these are the patients who benefited by adding this pertuzumab to trastuzumab. High risk patients included those with HR negative or N positive breast cancer. And another drug is oral neratinib that was approved in 2017 July. As extended adjuvant treatment for patients with HER2 overexpressed or amplified early breast cancer following adjuvant trastuzumab based therapy. Next slide. So how we rational to use in our setting by these three types of anti-HER2 therapy in adjuvant setting. As we know that neratinib is approved, but it's high cost and there is no any generic available and lesser availability of this drug also. Pertuzumab, however, discovered by as Parjita, but biosimilar also available at time now. And TDM1 is the trastuzumab emtansine and also biosimilar available for this. Next slide. So using these drugs definitely reduce the cost of the treatment of the anti-HER2 therapy. So TDM1 in EBC, a Catherine study design prior neoadjuvant therapy consisting of minimum 6 cycles of chemotherapy or minimum 9 weeks of trastuzumab. Second, HER2 target agents allowed. Residual invasive tumor in breast or axillary nodes is the key factor. A randomization within 12 weeks of the surgery. One up to 1 ratio is planned, and TDM1 3.6 milligram per kg intravenous every 3 weekly for 14 cycles were planned. And if not given, then trastuzumab on per previous therapy 6 mg per kg every 3 weeks for 14 cycles was planned. Radiation and endocrine therapy if ERPR positive or if high risk disease radiation was planned, it goes through as per protocol and local guidelines. And switch to trastuzumab permitted if TDM1 discontinued due to the adverse events also. So primary endpoint was the invasive disease-free survival, and secondary endpoints was the IDFS with second primary non-breast cancer and disease-free survival, overall survival, etc. Next slide. So this study was phase 3 study of adjuvant trastuzumab emtansine versus trastuzumab for residual invasive HER2 positive early breast cancer after neoadjuvant chemotherapy and HER2 targeted therapy, mainly trastuzumab. So next slide. So this graph is showing that updated analysis till 2023, median follow-up of 8.4 years. And invasive disease-free survival was benefited while using TDM1 in spite of trastuzumab. And the hazard ratio was also 0.54, that is low, and it's shown the very good response rate comparison to the trastuzumab. Next slide, please. And updated overall survival was also improved while using TDM1 over the trastuzumab. TDM1 is the first therapy to show significant overall survival improvement in this setting. So absolute overall survival benefit was 4.7% at 7 years, and hazard ratio was also low at 0.66. Next slide. This is the final invasive disease-free survival by subgroups. The clinical age inoperable or operable, hormone receptor status either positive or negative, trastuzumab alone pre-operatively or trastuzumab plus additional HER2 directed agents were also scrutinized, not positive and not negative, or even central HER2 status by IC, even 0 or plus. Some patients were also enrolled. So overall, when we see total comparison, the TDM1 while using after trastuzumab in adjuvant setting, in especially in residual breast cancer after NSCT, all parameters show betterment by using TDM1. Next slide. So TDM1 has shown promising result even in patients with small residual tumors. This graph shows that all parameters are better with the TDM1 use. Even residual disease less than 1 centimeter with negative axillary lymph node, YPT1A, YPT1B, or YPT1 micro and YPN0 also shown better 7-year invasive disease-free survival than trastuzumab. Next slide. So, how these results are important in HER2 positive breast cancer? Catherine has introduced a new decision point in HER2 positive early breast cancer. Post neoadjuvant treatment should be optimized based on response to neoadjuvant chemotherapy. As when newly diagnosed high risk HER2 positive early breast cancer, then we use neoadjuvant therapy for 4 to 6 cycles, then underwent surgery and assessment of residual disease should be done. If there is pathological complete remission, it means YPT0 and YPN0, then continue the same trastuzumab or plus minus pertuzumab based adjuvant chemotherapy and should complete total 18 cycles. But if there is non-PCR present or residual invasive disease present, then opportunity to tailor the treatment to higher side with the drug TDM1 in an adjuvant setting. So recurrence rate should definitely will be lowering. Next slide. Proposed strategy for the managing patients with stage 1 to 3 HER2 positive EBC. If tumor size is more than 2 centimeter and lymph node either negative or positive, neoadjuvant chemotherapy with dual HER2 blockade, trastuzumab and pertuzumab when applied, and then after neoadjuvant chemotherapy completed, after then adjuvant surgery should be done, and it further scrutinized into pathological complete remission and non-pathological complete remission. So if pathological complete remission, then continue trastuzumab for 1 year and add pertuzumab if lymph node positive. But if non-pathological complete remission, then TDM1 should be recommended for 14 cycles every 3 weekly. And if disease is very early breast cancer and CT1 and CN0 early breast cancer, then upfront surgery can be done. And if pathological T1 present, adjuvant paclitaxel and trastuzumab based therapy should be given. And if any lymph node positive after surgery, then adjuvant polychemotherapy with dual blockage, especially if lymph node positive, like trastuzumab and pertuzumab is indicated. For all patients, if indicated, radiotherapy and or adjuvant endocrine therapy should be continued. Next slide. So, on conclusion, for patients with HER2 positive breast cancer, the accessibility of HER2 targeted agents have markedly and rapidly improved the overall survival and overall outcomes also. Need to offer neoadjuvant treatment for most of the eligible HER2 patients to adopt the response-based treatment modification. For adjuvant therapy, Catherine trials suggest that TDM1 as adjuvant therapy for patients with residual invasive disease after neoadjuvant taxane and trastuzumab-based treatment. More confidence with neo data has been shown. And affinity trial shown that dual HER2 therapy with trastuzumab and pertuzumab either continued for a total of 1 year after neoadjuvant chemotherapy or with adjuvant chemotherapy for a total of 1 year, especially for lymph node positive patient. Thank you.
Thank you, Dr. Manish. Thank you very much for your nice talk. And
Thank you.
yeah, now actually, Dr. Vikas Talreja was supposed to do this talk, but as he is not here, he has some emergency. So we are not going for this panel discussion. So I seriously apologize with our panelists who were waited so long. But as there was unforeseen circumstances with Dr. Vikas Talreja, so he is not been able to present this moderation. So we'll end here, and thank you everyone who has participated today. And actually, the surgical sessions and the medical oncology sessions were very nice, and it has given a lot of information to us. And thank you very much for joining us in this platform. And with your participation, only this platform can be utilized in the patient care. Thank you very much, and we'll see you tomorrow with the GU session. Thank you very much. Thank you, team Horizon.
Thank you, everyone.
sir.
Thank you. Good night, everyone.
Good
And
night.
we'll join tomorrow at the same time.
Yeah, thank you.
Thank you, Sakshi. Thank you, Nishant.